Hello, everybody. I'm Lisa Kaliz. I'm the educational lead developer with postgraduate medicine, and I am also the CBME co-lead with Parveen Wasi. And today you are joining the CBME annual retreat, our second webinar of a 3-webinar series. It's called Case-Based Discussion, Good Data In, Good Decisions Out. And we have a really interactive case-based session for you today, and we don't want to delay because we want to leave lots of room for discussion and some small group interaction. So I'm just going to advance to the agenda slide and review just how the activities are going to roll out. But first, just want to thank, sorry, Allison, I do want to thank the CBME Retreat Planning Committee. They did extensive work, really active and hands-on, putting together 3 webinars in these series, and it's just been wonderful. And we think there's going to be a lot of great learning and discussion. So thank you to all of our faculty and staff. There's our list of facilitators for today and our competency committee chairs who will be running our small group sessions and chairing a mock competency committee as part of the activities. Thank you to them. So just a quick review of how it's going to roll out. We are going to move through a case presentation, large group. Dr. Callan will lead that. Then we're going to break out into small groups, and that will be facilitated through our leaders there. They're on the right. And there are a number of probing questions that you're going to work through as a group, and then regroup in large, come together again in large group and review the discussion points, the key issues identified. And we're going to use a number of different polls throughout the session just to get some feedback in from the large group and small groups as well. We have a second case as well, which we're going to roll out as a mock competency committee, and then we'll regroup again after that with a large group discussion and debriefing, and then wrap up by 5. Okay, Trainee Basilios will take us through our learning objectives.
Hello to everyone. Good afternoon. Thanks for joining us. We are very excited to be here and to learn with you. And our group, our planning committee came up with some objectives that we think are relevant. And to start with, our first objective is to really learn, or at least get an introduction to how to navigate the different assessment data that's available on MedSIS, relevant to a performance review or a progression decision. And to look at this quantitative as well as qualitative data to make a determination regarding status and progression recommendations. We're going to spend some time discussing how we can help enhance the quality of the data that's gathered and the process that we use in order to optimize competence committee reviews and decision-making, as well as to encourage resident self-reflection and self-directedness. There's a lot of gray areas, and we're going to work on talking and identifying some of the gray areas of trainee performance reviews and different factors that can influence competence committee decisions, as well as trainee progress, promotion, and remediation. And so the first case that Dr. Callan is going to present is going to walk us through some of these objectives. He is going to walk us through the process of navigating the assessment data, as well as looking at the quality and the quantity of the data. And that's before we have a bit of a discussion and then break out into our smaller groups. So Dr. Callan, to you.
Thank you very much, Irene. So I'm just going to share my screen. So just give me 1 second. And if you can see it, just give me a thumbs up. Good, everybody can see it. And can you see my little arrow going around too? Yeah, good, excellent. All right, well, thank you guys all for coming. Just to introduce myself, my name is David Callan. I'm one of the pediatric neurologists, and we moved to Competence by Design actually just this year as a specialty, but I've been a part of the Competence by Design in the post-grad world from the time when we started the committees. I've recently begun to be the chair of the Learner Development Committee, and I spoke to that at the last webinar with an update. So I am going to go through a case, and it's a mock case. And just so you know, the data has been all although it's kind of based loosely on real cases, it's been modified and it's been completely anonymized. And so although it says it's associated with a specific program, we really have tried our best to make it such that no one would be able to identify this person. So it's all been completely modified in that regard. But what I'd like to do is just walk you through the case, and we'll try to see what it's like to actually use our MedSIS platform to walk through it. Originally, we were going to get Chantel, who you met at the last webinar, to do it as we spoke, but we thought that that might be a bit challenging. So I've done it and put it in a PowerPoint presentation. But I think that it will give you a sense of what it's like, and I'll try to bring out some of the various facets that you can use to glean different things from the data. So happy to answer questions once I've gone through the PowerPoint. We will have some opportunity to have some discussion afterwards as well, but we are going to be going into small groups to discuss the case. And so at the end of this, just to begin, as is in the 7 Habits of Highly Effective People, let's begin with the end in mind. And so our end in mind for this case is to decide, is this resident that I'm presenting progressing as expected, or are there issues that we need to identify and support this resident with? So without further ado, Molly, as you can see here, is a nephrology resident, and she is just finishing the foundations of discipline. So she has previously been assessed in July of this year, and she was progressing as expected at that time. And she's currently up for regular review. She's at the point where she is at the end of her designated block for foundation rotations, and would be moving on to core. So if we look at her dashboard of her EPA, so we'll start there. So this should be familiar from previous presentations of what MedSIS looks like. For those of you who haven't used it, I'll just point out a couple of things. So we're looking at the foundations of discipline. And so we've expanded all the EPAs. We've collapsed the EPAs for transition to discipline because she was successful in moving on to foundations. According to MedSIS, she's accomplished 87% of the EPAs for the foundations of discipline. And as we can see on this first screen, we can see that there are 4 different EPAs, and all of them are annotated to be 100% completed, meaning she's achieved all of the contextual requirements successfully and has achieved an O score of 5, an adequate number of times from appropriate individuals, whether that is staff or whether that is a more senior learner. Everything looks good from this screen. And just to let you know, this is the EPA. It's the overall EPA. It's been expanded to show the contextual environments. So for the initial EPA, you needed to do it. It needed to be observed 3 times getting achievement. It had to be whatever, I think of this as acute kidney injury. I'm an N specialty, but not the right N specialty for this. I'm a neurologist, not a nephrologist, so I'm just guessing a little bit with this. So bear with me if I get something wrong. And if anyone's a nephrologist, you can throw things at me if I get things wrong. So and then it has to be in one transplant patient. So that's just what this is. These are the contextual variables. And then over here is your O score, with this being 1, 2, 3, 4, 5, with 5 meaning I didn't need to be there. And so you can see how many they have achieved just by looking at the rainbow here. If we look, let's say we wanted to look at one of these in a bit more detail, we could potentially just click on it and it would open up the breakdown. And this is what you're going to see on your learner review sheet. And it breaks down. So this is for dialysis orders, and it shows you the breakdown, which we already saw, but then it breaks it down into the milestones. And so you can specifically see which are the milestones that were covered in this specific EPA and how well they did on those milestones. So again, we have when you go through the milestones, you expand it, the milestones are either going to be, you didn't see them do this, and so you can't really comment, they're still working on it, or they have achieved it. And so you can see that for this EPA, when we look at all the milestones, we've got a nice balance of them being achieved, and the not observed is relatively small. We also have some comments on the bottom here that can be used to supplement this information. And this is where we get into a little bit of the data in, data out, and figure out whether or not, or what kind of comments are actually going to be useful versus not useful on these forms. So thus far, everything looks pretty good, but we can't just have a pretty good case because then we wouldn't have anything to discuss. So let's look a little bit closely at the next screen. So this is looking at the rest of the EPAs from foundations. And you can see that here's why she wasn't at full 100% in terms of her completion of all of the foundation EPAs. And that's because she is red on EPA number 5, which is consultative care, and yellow on 6, which is peritoneal dialysis, common complications. So let's look a little bit more closely at these ones. So sometimes it can be clear from the contextual variables what is the issue. Is it that they haven't done it with staff, or is it a specific patient population? So if we look at the consultative care and we look a bit more closely at the contextual variables, it doesn't really give us a heck of a lot of information. It says that basically she needs to do more observations because there's really only been one observation of achievement, and it looks like there needs to be 4. So she needs to do this more often. That's what we get out of this. And at least one of the times where she does this in the future, it's going to have to be with a dialysis patient. Okay, so she needs to do it more often. Let's look at the comments from the EPAs. So, and I'll just read it out so that we can all follow along. So the one comment was, our patient had symptomatic anemia and was treated with darbepoetin, forgive me, and developed an acute drug reaction. All I had to do was interpret the chart note for Molly. She contacted Dr. Pepper, the person, not the pop, I'm assuming, and solved the problem, fixed the documentation, and arranged for education and initiation of the darbepoetin Puyitan in a safe way. I was very impressed by the completeness of care arising from a single clinic visit. This was not her longitudinal patient. And then another comment was always have a clear rationale for all management plans and be prepared to clearly and succinctly communicate that rationale. So I don't know about you, but looking at this, I don't really get a sense of, are there any issues or not, or why isn't this being completed more when all the other ones are? So then we can look at that other component that I showed you before, and we can look at the breakdown, and we see that there's really only been 4 attempts, so there probably needs to be more attempts. So maybe that's just the issue. But if we actually look at the milestones, what we see is that from a medical expert perspective, she's doing well. Like she's achieved this in all 4 times she did it. She achieved this. But if we look at the intrinsic roles, the non-medical expert roles, we see that most of the time these either are not observed or in progress. So it makes you think, okay, so this is consultative care. Is there something going on from an intrinsic role perspective? Because the medical expert stuff seems to be ticking along the way it should. So that's just something to keep in the back of your mind. But let's see if the trend continues. This is just another way of looking at it. So whenever you're on MedSIS, what you can do is you can show graphs of all the milestones and how they're achieving them. And if it's grayed out, that means that it hasn't been observed for this number of encounters. Yellow is in progress and green is achieved. And again, this just is a graphic way of showing that the medical expert ones are either have been in progress or achieved, but the ones that are the CanMed's collaborator and professional either haven't been observed or are still in progress. So this is just another graphical representation of the same data. So if we go back to our dashboard and then we focus in on the other EPA, so this is now peritoneal dialysis complications. Again, if we look at the contextual variables, so this one, she hasn't been observed by a nephrologist. So maybe it's avoidance of staff. I don't know. It's just something to consider, and then needs to do it in a specific scenario. If we look at the comments, so coherent, well thought out plan, inadequate dialysis, adjusted prescription, and then peritoneal dialysis with chronic volume expansion. Dr. Denton identified the need for further filtration by peritoneal dialysis, discussed ways of achieving this, including glucose exposure and shorter dwell times. So none of that means a lot to me in terms of looking at this as to why she hasn't been successful in this EPA yet. Maybe it's just numbers, I don't know. Again, let's look at the breakdown, and we see all of the medical expert ones. Again, we see this trend of them being achieved, whereas the intrinsic roles, they seem to be either not observed, in progress. This one is achieved or not observed. So is there something in the intrinsic roles that's coming out? Again, the graphic representation showing the medical expert being achieved, but the non-medical expert intrinsics still lacking. So many programs are doing more than just the EPAs because they're a little bit reluctant to lose that overall gestalt of the rotation. And so they're continuing with the ITERs. So if we look at her ITERs, clearly this is a very useful way of looking at them, right? And this is why we've probably moved away from ITERs, in that it's this whole concept of failure to fail. everything is satisfactory on all of the rotations. Now we could dig into the various components of the ITERs, but let's look at the ITERs in terms of the comments. So pleasure to work with. I enjoyed my time on service with Dr. Denton. Okay. Please contribute more of your knowledge to both in clinical rounds and teaching rounds. This will allow for a more fulsome evaluation and will allow you to contribute more to the education of juniors. So again, this is speaking more to that intrinsic collaborator communicator role. Quite competent and knowledgeable, but is very quiet, and it takes an effort on the part of the evaluator to draw out her knowledge and abilities. Very polite, kind, and respectful. There are a few things we discussed on service. Furthermore, Molly can be more confident and make more definitive plans as a consultant. So that gives you an overview of this case. And what we'd like to do is, if you were in this competence committee and you'd heard this story and reviewed this data, we would want to know what your thoughts were. So I'm going to let Allison put forward the poll for you. So would you say, is this resident progressing as expected, not progressing as expected, or accelerated? And then if we're looking at this in terms of the narrative comments.
Here's your results, Dave.
All right, so I love the fact that there's a difference between question 1 and question 2. Obviously the intra-rater reliability isn't great. So it seems like the group is leaning towards that this resident would be not progressing as expected, but it also seems like there's some people who think that the resident should be progressing as expected. So what we're going to do right now is we're going to break into some small groups, and we're going to have facilitators associated with the groups, and we're going to answer some questions. And we've assigned different groups to different questions, but if you get through your questions from the group, then you can do more. So just to go through them, do you agree with the large groups review? So that would be not progressing as expected. What might help or hinder a progression decision-making process? If any, what assessments, in addition to the CBD, like all the forms that you saw, do you think would be useful to help make this discussion or make that decision? In scoring the high yield milestones, essential to, scoring the milestones essential to assessing competence beyond the medical expert role? Discuss the advantages and disadvantages of shared responsibility of EPA observations by faculty and trainee. When is it advantageous for a faculty to trigger an EPA? When is it advantageous for a trainee to trigger an EPA? And one of the things that you might note is that the number of EPAs triggered by this resident was relatively low. And so maybe there can be discussion about that as well. Residents who are welcoming formative feedback, what are the things that we need to give them to allow them to have that growth mindset for formative feedback rather than just feeling like it's negative? And then we want you to tell us what are the things that would improve the quality of data in so that we can make good decisions out. So at that, I will stop. And I think we're all going to be split up into our breakout rooms.
Correct. Thanks, Dave. So just a reminder, there's 5 or so questions. Each group has been assigned at least 2 to capture, but there's nothing to stop you from discussing all 5. And when you come back into large group, we'll review and we'll see what everybody's thinking process was with respect to those 5 questions. Okay, so Allison, you were going to launch a poll and we're going to see, is there been any shifts in terms of what people were thinking? And then Dave's going to take it up and go through the Dave and Rainey will go through the groups and get some feedback on some of the questions that were discussed. Okay, everybody's in. Did you want to pick up with the results? Rainey and Dave? And this is interesting.
Okay, so obviously I biased you guys and then people dragged you back to the other side. So yeah, we came to we've shifted our viewpoint, and I'd be interested to hear what people have to say. So maybe I can, and I don't know that people necessarily, I don't know if I was in the right group or not. So I'm actually just gonna call out the representatives of the group, and that maybe they can kind of give a synopsis of what they found. So why don't we start with group 1, which I think is Dr. Yang's group. Is that right?
Yeah, no, that was my group. You know, I'm not sure we really addressed exactly the top 2 questions, but it's interesting. Just with the poll and the changes that we saw, I don't think our group necessarily changed our views in terms of where this resident should go, in terms of how the original review and the results went. But we did have a pretty fulsome discussion with respect to the communication of a decision to the resident. You know, if that, you know, sometimes it was pointed out that sometimes the decision of not progressing as expected some residents may find that difficult to take, especially if they're not accustomed to receiving such feedback. So we talked about perhaps the strategy of giving forth a recommendation of progressing as expected with the condition or with the provision that they address these specific deficiencies that were identified with respect to the intrinsic competencies and so on. So I thought that was quite valuable, and certainly something that we had seen in our own programs as well.
So that almost speaks to the concept of the growth mindset, and what can we do to try to encourage this to be more of a coaching and not as a negative thing, but hey, here are some things that you can do to make yourself the best nephrologist that you can be. So changing to that growth mindset. And I see Teresa nodding her head. So I know I'm on the right track. So, okay, that's great. So, and it sounded like you guys landed on not progressing as expected. So maybe, I think that Lori, you were next. Do you want to talk about what your group discussed?
Yes, well, there's more than one facilitator. Maybe I'll just take the next question, number 2, Dave. Shall I do that?
Sure.
Looking at what assessments, in addition to the CBD forms and ITER, would be useful. And because it was identified that on the ITER comments and our EPAs, that it was the intrinsic roles, namely collaborator, communicator, a little bit of professional, with the ITER saying there was some problems with confidence and being quiet in discussions, not really sharing on multidisciplinary teams, that sort of thing. We thought how important it would be to look at other assessments based on performance, such as presenting grand rounds, presenting rounds to teams of learners, M&M rounds, OSCEs, that sort of thing, to look at her performance in those domains and see if it crosses over into those areas. That may help be more descriptive in terms of defining where the problems lie, the intrinsic variables. It may simply be shyness, or maybe she feels that her knowledge base isn't adequate and doesn't like to put herself forward, but it may be a little bit, provide a bit more insight and help the committee make a decision at this point. And then of course, when it's passed on, thereafter help with a plan.
Yeah, that's great. And again, this is another one where maybe if the program had a 360, that would be a useful tool to get that multidisciplinary perspective and see whether or not this is just a sampling error, or is this a truth about this person? So yeah, that's great. Okay, so Val, I think that I deserted you and went to a different group. So you ran the group on your own. So go ahead.
Actually, I didn't. I went to group 8 and Diane came in and facilitated that. So
okay,
I
all
got
right.
on mixed up too.
Okay.
Well,
While we have you, do you want to tell us about what your group talked about?
We talked about.
so I will let Val.
Sorry, Diane.
Val,
Do you want
back to Val.
Okay. We talked about much of the same things that were just being mentioned. We talked about using multi-source feedback. We talked about the use of other types of assessment, like using OSCEs with stations that were really focused on communication. We talked about using simulation and looking at the different roles of professional collaborator, communicator within scenarios, communication skills scenarios. And we got into a bit of a conversation about the mini CAX and whether that could be used as well.
Okay, thanks. So I ended up being in the next group, and maybe I can tell you, because I think it's an interesting point, and it's something that perhaps we need more faculty development on, or maybe we even need to know a bit more. And that is the whole concept of, can an EPA be completed, and can it be considered to be successfully done if no one has observed one or two of the milestones? So if you look on some of those successful milestones, so I don't know if I think I can share my screen, right? So if we look at, for example, you guys can see that now, I think. So we look at acute kidney injury. It is 100% complete. There's been 9 observations, 4 of which have received 5. And yet if you look at the collaborator role, there's 0 achieved. And so is this an adequate representation of this task? Can you say that they've successfully completed this task if they don't have the collaborator? And then there's the, again, yes, Teresa brings out this point that they don't need to do all the milestones within an EPA for it to be successful. Now, for those of you who went through the Royal College workshops, you'll know that there's some milestones that were bolded and some that were not bolded. And the bolded ones are supposed to be kind of the important ones that you should be seeing. And in fact, I think, correct me if I'm wrong, I don't know if Chantal is on this, but it's only the bolded ones that are put in MedSIS for us to expand on. And so we don't even see the non-bolded ones. And so these are the ones that are really felt to be important. And I guess the concern is, if you can say yes to an EPA without observing these, it could be that all of these EPAs are, they're all green, and yet the collaborator role has never been achieved in any of them, right? And so that's a hole. And that's something that probably either needs to be picked up by the competence committee, who is thoroughly going through this and saying, yes, but this is fine, but we don't have the collaborator. Let's look and see if the collaborator's been dealt with elsewhere. Also looking at those graphs that I showed to see which are the ones, like which are the roles that are not being completed. Sorry. And so I think that it raises a concern in terms of holes that can be there in our current process. And maybe it's something that competence committees need to be aware of. I see some chat stuff in the chat.
Yeah,
And
sorry,
so-
I was just going to add and amplify something you're saying. I think a big part of what has been in the chat is Diane and I were respecting the fact that not everything needs to be marked at all times, but that there are trends, right? So if there's avoidance of a certain intrinsic role, I think that should be a signal that you should be privy to and try to detect. I think that between the academic advisors and your composite committee, that those are two things that you can try to be looking for. I think in terms of other things to pay attention to is that the CanMeds rules per the Royal College is supposed to be baked into the EPA. So even if no one's specifically called it out as something that they need to observe within that EPA, it's supposed to be a part of it. So looking at the overall comments for that EPA will also be useful to think about whether or not there are other context that has already been alluded to within the other EPA commentary that can lend credence to the observation of whether or not there's a score or anything like that on it, but rather look at the qual as well to really augment your decision around whether there's a signal within all of this noise. So I think that's just my perspective on that.
That's great. Now, there's a hook around my neck and I'm going to get pulled off. So I'm gonna let that happen. Just one take-home point from this is just from that discussion is that even if MedSIS, like MedSIS is great, and I'm just saying that because Chantel's on, but MedSIS is great, but you really need to actually look at the various milestones. You can't just accept it at face value. I think that should be a take-home point. So let me pass it along. I think it's Haroon. I don't know if you're going to introduce yourself or somebody's going to introduce you.
Oh, Dave, we got some audio, or yeah, we had a little trouble hearing you there.
Okay, I'm sorry. So
I did just message everybody that we're a tiny bit behind, and so we can have pickup points.
So go ahead, guys. I was just going to pass it on to case 2.
Perfect. I think I'll start. Sorry, I have my video off because the HHS network gets choppy when I turn on my video. So you'll just be seeing a faceless screen. I'm just going to start sharing my screen. Okay. David did a great job of going over the overview of how things appear in MedSIS and the EPA completion. This particular case is will be going a bit more into the into the nitty-gritty of the feedback that's given in the IDERs and see if there's any signal that may be concerning or not. Okay. This is a case, and I've kept in the PDF because we'll be reading some of the evaluations, and they get a bit too compressed in PowerPoint. So this is Jamil Fields. He's a PGY5 in nephrology, and currently we've already had the previous competency committee meeting in July, and he's was thought to be progressing as expected, and now we're reviewing him in September, October to see how he's doing. He's currently in the core of discipline, but in the next few months, like 1 to 2 months, he'll be into the transition to practice. So this is an individual who's transitioning into practice, entering into the transition into practice realm of their training. And so we really have to be keeping a close eye on whether they're going to be having the skills necessary to transitioning to be an independent practitioner. Okay, so I just want to keep that in mind as we go through this learner summary report, and I'll be summarizing some of the things that I felt when reviewing this case were important, and would appreciate your feedback once we get into the breakout rooms. Okay, so when we look through our first couple of EPAs, and what I through reviewing this case, much like the previous case, is that there weren't really many concerns from the medical expert role. So if you look at AKI and establishing a plan, a comprehensive plan, you can look at the EPAs and you can see the comments in the EPAs, and that's what we're focusing on here, is that, you know, the knowledge base was good. Jamil made the effort to look at urine, no concerns, but there's a signal here that he had limited communication with ICU staff. Depending, but there's limited communication. This is something I see happening repeatedly in a number of the EPAs. In terms of establishing a comprehensive plan for patients, he's got a good approach to case. He's got a clear plan, so it appears that he's, developing strong plans. But again, there's the ensure the patient knows you're aware of their preferences, concerns, and incorporate into plans. So he's not really incorporating preferences and concerns into plans. Okay. Acute urgent orders. It looks like he's got good initial efforts at medical therapy, tries to initiate plans, create plans on his own. So that's good. In terms of hypertension, assessing patient, patient assessment and management, again, looks like the management plan, the thinking, the medical decision making is actually going quite well. Okay. In terms of hypertension, it appears that he's deferring initial treatment, but not and focusing on counseling. But when he's doing the counseling, they're not really exploring issues of weight loss and other barriers to treatment. So again, some of the nuanced communication is not happening, and that's really something I find as you're transitioning to becoming an independent practitioner is important. In terms of electrolyte abnormalities, initial investigation management of them, these appear to be going fairly well. There's just a comment on refreshing knowledge of hereditary causes of nephrocalcinosis, but this seems to be going quite well. So now we move into living donors. So some of the transplant modalities within nephrology, and in terms of assessing the suitability of potential living donors for kidney transplant, it appears that Dr. feels Jamil has been doing quite well. He's done some good job with consults, and he appears to assess people for candidacy for donor transplant quite effectively. So, that medical knowledge piece, again, looks like it's quite strong. Okay, same thing when he's on suitability, assessing the suitability of deceased donors for kidney transplant. It appears he's able to make those decisions quite well. There's even comments around good work and how he's doing this, doing these assessments effectively. Okay. Recipient eligibility, so there's a bit of a gap. But this is basically assessing whether a person is eligible for receiving a kidney transplant. It appears that, again, Jamil's knowledge base is quite good. He's reviewed the case well. He's able to know exactly what needs to be improved prior to transplant. But in this case, it looks like there's a question again, if Jamil's aware of all the milestones he needs to have gone through before being considered for this program. So again, the medical standpoint in terms of getting the ECGs, getting the blood work ordered, he appears to be doing quite well. Okay. Again, in terms of immunosuppression, and this appears that and treatment of any complications around transplant, it appears he's able to do those effectively, and no issues from that regards in terms of the collaborative role. He understands how to do immunosuppression, and the staff feel that he's quite comfortable in thinking through the management of complex patients. And so then we get into some of the written communication of patients. And you can see here that there are about 3 forms, and there's that he's asked to get completed. And there's in this breakdown, you can see some of them he's gotten a 3, some a 4, and 1 a 5. Okay. And then we look, it's important here that we look at some of the comments, and I've bolded some of the things that are important. So this is a longitudinal clinic where Jamil is managing patients independently. And you can see here that in the longitudinal clinics, there were issues regarding documentation on multiple occasions. And your longitudinal clinics, when you're at a fellow level, you're largely functioning quite independently with some very high-level supervision from the staff. So you really have to take ownership of these patients. And so in this case, multiple issues with documentation. He was, in addition, the documentation of his plans and descriptions of his plans are quite brief. And the documentation of these clinic visits are often quite incomplete and delayed, okay? So that's concerning, particularly for someone who's about to start practicing in about 8-9 months independently, okay? We move into providing comprehensive care to patients with progressive kidney dysfunction. And in this case, again, he appears to be creating good plans, but and there don't seem to be any issues here. But as we move into more the longitudinal management, and again, the dialysis is going fine. And we move into the more complex management. It appears that he has to be prompted for plans at some points for small things like laxatives. But I'll move on more to the dialysis complications. And over here, you can see that he's appropriately managed the common complication of peritoneal dialysis. But there's a comment here about ensuring documenting complications and disclosing patient safety incidents in the chart. So I don't know if this individual here felt that he didn't do it or why this comment is made, but it makes you wonder why, again, with the previous signal of not documenting, is he not documenting patient complications? Then we move on to health literacy, and it seems that Jamil is able to discharge patients, and he's able to support them. And in this particular case, that he was able to actually work with a multidisciplinary team to create a safe plan. So there are episodes where he appears to be collaborating well. But then we move into the longitudinal aspects of care in the clinic. And again, it appears to be that Jamil knows the patients quite well, but there are times when investigations are not followed up on and documentation is incomplete. Then we move on to the EPAs around interprofessional team. And so in these ones, you can see that he's gotten 3 forms done and 0% completion. So it's a bit concerning that at this stage, what's happening in terms of the work with the interprofessional team. And so in this comment, the staff is observing Jamil at multiple multidisciplinary rounds. It appears that Jamil, when he's present, is a effective contributor. However, he missed almost half of the interdisciplinary rounds, which are typically run by a fellow, and then even when he's late or not present, he's not informing any of his other team members about being in these, not being able to come to these rounds. We'll then also look into the teaching role. And you can see here that at times the individuals found that the medical students found him to be a bit intimidating, and that he wasn't teaching to the level of at their level. So those are some issues at the EPAs. We then move on to the IDERs, where there's more narrative comments. You can see knowledge base is quite good, no issues there. He's able to identify important issues for CKD patients. But again, the issue of not dictating notes, and then when he's given feedback about not dictating notes and not documenting effectively, he becomes quite defensive and doesn't seem to be transitioning to a leadership role effectively. So this is like, as both Teresa and David were talking about the growth mindset, I don't know if he's necessarily entered this mindset and actually becomes quite defensive. Okay. Again, documentation is the issue again in the longitudinal clinic, where he's been managing patients over the past 9 months. So that, from a patient safety perspective, that's an issue. So really, summarizing this review done of Jamil, he appears to be a medical expert role, doing things well, but some of the intrinsic intrinsic CanMed roles, such as being an effective collaborator, being an effective communicator, and just overall professionalism in terms of being present at meetings and visits that you're supposed to. Jamil is not really doing that. I think we bring up our poll and we can talk about the competence committee, if you were on it, what would be your thoughts about the next steps for Jamil, particularly keeping in mind that he's going to be entering the transition to practice soon. So Allison, if you can put up the poll. Okay. So we see.
Did you see them? Okay.
Yeah, I can see them.
Okay.
So in this particular case, I think we have a reasonable distribution. A lot of individuals say not progressing as expected, and that's about 70%, and about 25% say failure to progress or inactive. So I think it'd be an interesting discussion to have once we break out into our breakout rooms. So I think Allison will be doing that. And Allison, will you be, I think you emailed out the revised PDF for the.
Yes, I did.
Yeah, perfect, good.
Now when we're getting in our groups, the thought is that we're going to mock so right now who is presenting as a primary reviewer to the competence committee, which is going to be you in groups. And there may be a secondary reviewer who wants to speak up, but really it's a time to talk as if we're in a mock competence committee.
Yeah.
Looks like we're filtering back into the main room. Still waiting for a few more folks. And then we're going to pick up with a poll. This poll will have two questions. One will be what your thoughts are, what your group's thoughts are about the trainee status, and what your recommendation to the RPC would be as a competency committee. Okay, there's some results there. And Haroon, Diane, and Parveen, if she's in, can chime in to this case review, large group discussion around the results here.
Yeah, so maybe we could hear from some of the groups as to what you discussed, and then we can talk a little bit about what in my own group what we had discussed about, and then we can maybe get into more of the nitty-gritty of how to proceed with this case. Does that sound? Oh, we have 13 minutes. I'm thinking maybe we should just move ahead to talk about some of the nitty-gritty in terms of the next steps, just in terms of, because time is so limited. I know in our group we had talked about how these concerns are some of the things that could lead to a lot of issues from a CPSO perspective once you're in practice, and how concerning that is. And then we had talked about if we're not progressing someone, what are the next steps and how we can support them, because this individual is very close to being independent practitioner, and we may need more time to help them work through these issues. I don't know.
Haroon, this is Teresa. Our group, I think we talked a little bit about all of that, and I made a joke how this is probably the misnamed, but the correct person might be Gregory House with the name of this this candidate, and that otherwise, like, you can show them like that is their possible future if they don't kind of shape up. But I guess our group spent a little bit of time, and I dropped the analogy that some people might want to steal, and go ahead if you want to steal it. It's the idea that as an emerge doc, if I were to just hand over to you as an internist needs admission as the only the only thing I said to you, and I walked away, you might not be very happy with me. And I think that I think of the different categories in the CBD recommendation as more like disposition, but aren't the more nuanced part of maybe an early differential diagnosis or a diagnostic decision as to what's going on. And right now, I don't think I have enough information, for instance, and have a differential for what I think is going on. But I don't know if I have enough information. And I think we linked it to the discussion that we had last time, because we had that one of the groups that talked about what other information you need. And the idea would be, what else could we figure out? How can we help this person continue to continue to progress and move on? And so trying to figure out if the differential is mental illness, for instance, if it's situational, if it's that they're overwhelmed with like a new AHR, for instance, that they're coming from somewhere else, et cetera, et cetera. I think there might be a wide differential this time that manifests the way it does in the records, and that further diagnostics would be required, right? Because if you go to the multidisciplinary rounds and everybody's like, oh, that person's wonderful when he shows up, that's a very different thing than everyone rolls their eyes and avoids answering the question of what you think of them. That's a very different situation, right? And so I think it's important to think about some of those things, so that it's definitely worthwhile kind of thinking through how you would move through this, and then decide on which level of disposition you think is important.
Yeah, we had brought up there may be some personal issues that may be driving this, because it's previously, at least, is progressing as expected. Lisa asked a great question, that those that arrived at failure to progress, what were your most compelling factors for choosing that, if you did choose that?
I can speak to that. Actually, we went with what was on the guide, where it said that on his previous conference committee, he was not progressing as expected. And so that was one of the issues on making a decision. And we did think that, you know, the best thing for this person would be a remediation. And I think everybody else had covered quite well the issues that, you know, his having problems with communicator, you know, verbal communicating with the learners, communicating with other health professionals. The documentation, paper documentation is also a big issue. There's some professionalism, you know, when he's not showing up to meeting, and it's not telling that he's not showing up. Leadership role also seems to be a big problem also. And maybe there is, like Teresa explained, maybe there is another issue that we don't know, and that would be something that that person could talk with the program director. So I think that was very well said, Teresa. There might be other issues going on. Even though there is other issues, we're there to support the person and help with if there is other issues or not, and then making sure that they understand well that the remediation is not punitive, but it's more there to make sure that they complete their training, that they are competent, and that they'll be ready to be in practice, and also making sure that the insight is there. We felt that the insight was not there, which means that perhaps also having a bit of some self-reflection on what happened, why it happened, and is it correct or not. And then we brought up also the, you know, the McMaster policies about professionalism. That's a really good document to look at. Looking at their own documentation. They could actually do even a self-audit of their own charts and then realize, oh yeah, I'm not doing this, or oh, I'm missing all of this. So little things like that. I think that pretty much summarized what we've discussed in the room.
Well, thank you.
Island and Smriti, we had a discussion about remediation and other strategies, if they wanted to speak to that.
Sure. I'm happy to share just a quick thing, just an idea that came up in our group that Amadeo brought up that I really loved. You know, we're talking about potential ideas for this resident, this trainee, and I think you know, Amadeo brought up the idea that perhaps we can recommend you know, as much as is within the Competence Committee's role to recommend steps or suggestions to perhaps match up this trainee with faculty who have been known to be really good communicators or really good at those intrinsic competencies, documentation, and so on, and to spend some time with them. And you know, this is the first time it sort of struck me, because you know, we're used to thinking about those things for medical expert stuff, right? You just stick a trainee who's deficient in an area in those, but it's the first time I sort of heard about sort of concretely doing a similar thing for these intrinsic competencies, which I thought was very interesting. So
Yeah. And I think David asked a good question in the chat. Would you want Jamil to be your colleague or have like learners under his supervision? I think that's an important question. And one of the things that we were talking about is 9 months, if it's the actual time that's left, is 9 months sufficient to bring about those changes? Because oftentimes changes in the intrinsic CAN-MEDS roles, or if there's some underlying mental health issues at play causing this, can take longer to resolve than sometimes brushing someone up on medical expert issues. Yeah, like looking after family, like there may be other personal issues at play. So, you know, sometimes the timeline here is compressed to 9 months. So something like remediation or failure to progress actually gives you the breathing room to tackle these, because you may be able to extend the PGY's training and actually tackle these in a wholesome way. Yeah, especially if there's a sudden inability, right? So.
So some of the things we had prepared were some of the justifications for remediation. One of the things that you've illuminated is they're really shining in the medical expert intrinsic role, and much less so across a number of other non-medical expert intrinsic roles. And can that trigger remediation in and of itself? There are a number of issues that flagged, and we do have Parveen with us and maybe others that have been involved in remediation that could speak to kind of the policies and procedures and things to think about from a pragmatic perspective.
Yeah, I think we did talk about it briefly in our group, is whether this is a enhanced education plan or this is a full remediation. We landed from our group into that this is a remediation. And as Teresa and Haroon said, is the first part of the remediation was really to talk to him, have his academic advisor, program director talk to him to see what are issues. And as Teresa said, we did say that this is 9 months into it, and if dictations are falling off now, it's two reasons something has happened, or the fact is, which is unfortunately not that uncommon, is that it's just not been pointed out before to the trainee. So it's not uncommon that we see things that have been persistent to come up in their fourth year. So, we landed on remediation. We landed on failure to progress, which is actually a remediation. So I think what we kind of remediation does allow extension of training if that's required. It also, one of the reasons we did an enhanced educational plan in the past was, again, to deal with issues that perhaps were not as concerning, but also people used it because they wanted to avoid the word remediation because of the mandatory reporting to CPSO. And that happened quite a bit, and that kind of confused us a little bit, because we were trying to downplay it so that CPSO wouldn't get involved. CPSO no longer has that mandatory reporting, so that's actually great news. But we felt in terms of overall that the remediation, you know what, the bottom line is that I don't think either one is set in stone. Some people may want to go to, if they put failure to, not progressing as expected with an EAP, or failure to progress with the remediation. Our group went to failure to progress with the remediation. If he does not do well with the EAP, then the automatic next step is remediation. One of the things that I really kind of took into was, in terms of deciding about a big R remediation, was the fact that he had actually been told about these deficiencies at one point, became defensive, and also not so much the defensive part, but the fact that he didn't correct them. By the end of the rotation, they had remained by the end of the rotation. So he had an opportunity to correct. He also has a professional responsibility that if there are something going on, and I know we expect a lot of our learners and staff, but if something outside of medicine is really affecting your ability to practice, one of our professional responsibilities is to seek help, because when he goes outside in training and something like this happens in practice, we will have to rely on our professionalism, that we need to know
when we are not doing the job we're supposed to be doing. And that's part of this process, is that even if there is an issue, is how to help him recognize that issue, how to help him recognize the impact of that issue on his practice, and how to recognize when he requires help. I think those are really important points for residents, and because that's what's going to serve them well as physicians. So, you know, the policy, you can use the policy. You know, I think a lot of it is judgment. And if you look at the tips, the triggers for remediation versus the triggers for EAPS, they're very similar, right? And people can decide how they want to do it. In this particular case, we just felt the deficiencies were significant enough that this warranted a remediation. Plus, we'd also said failure to progress.
Thanks, Praveen. Just drawing everyone's attention to the fact that it is 5 o'clock. If you did have more questions or even comments, please submit any questions to Allison Paquette in the CBME office. We are going to pick up with Friday's webinar session, and we're going to start with a CBD panel. Every role is represented on that panel, and we'll address questions that came up during these first 2 webinars and share some discussion around that. And then the last hour on Friday is a newly added hour for sharing innovations and success stories in CBD and scholarly work. And so some of that is looking at the ITERs and the change in how the ITER might be used, the ITER itself, or abandoned altogether. And then some other scholarly work that's underway in our programs. And it's a great way to network and celebrate that success. So thank you to everyone, to the planning committee. It was great. I hope you enjoyed some of the discussion, learned a few new nuggets, and we'll see us on Friday. Bye, everybody.